Kierkegaard said, "Wherever there is a crowd, there is some truth." And the crowd out there is loud. So now so many doubts, so many questions. What's true seems blurry. But the truth really is what I seek.
I'm hungry.
Decisions. Easier to take in times of no social media. Whatever the doctors or scientists said, I did. They are the experts, not me, I thought. In fact, I still think so. But suddenly the number of experts out there seems overwhelming. Who to believe? What to believe? So here we are anyway. From a nearly vegan diet because some experts say it's best, to eating purely organic eggs from our own garden because other experts claim it's better. Confusion. And all to heal this tooth. Naturally. Why? The voices in my head speak up. More confusion. Oh, I've so been tempted to disconnect, flush my phone down the toilet. But then how do I connect? I may be British, but I'm still an immigrant. A Mexican, really, in the middle of the English countryside. A blessing and a riddle. Everyone so polite, yet everyone distant. My phone is where my friends are. Literally. They say it takes a village to raise a child. Pero ay, mi familia, mis amigos, mi lengua, las risas, las fiestas, las comidas, el ruido, el olor, el color, el aire, el calor, los aguacates, chicos zapotes, unas gorditas.
Hi everyone, really nice to have everybody here, and I really hope everyone watching and everyone who's just seen the piece has really enjoyed it as much as I have and as much as we have. So I think it'll be quite nice just to sort of go around and see what people felt of what we've just seen and how that sort of resonates with them and how it sort of fits into the antimicrobial sort of resistance and issues that we face today. I don't know whether Sue, you fancy kicking us off with what you feel?
I thought it was really interesting, and I think one of the things that it really brought out is that it doesn't matter what we do as professionals, that everything comes down to what somebody's actually doing in their own home with whatever information, with whatever supplies, whatever we actually give to them. And that we've got to be really clear about making sure that patients know what's going on, get access into enough information so that they feel empowered to look after themselves, to look after their families, and to actually take part in, particularly in this whole debate around AMR. And I'm hoping we're going to have a chance to talk today about how that fits in with clinical trials and how we get people to feel that empowerment.
Yeah, absolutely. I agree. Brendan, what did you feel about it?
Yeah, I really enjoyed the piece, and I agree with Sue. I think we have to, as scientists, have to give people the tools and enable them to understand and have sufficient literacy around these issues to make clear decisions about their own healthcare, about how they sift through the wave of data that comes and information and misinformation that comes to people day and daily through various channels. So it really is, I feel, incumbent on us, learned societies, universities, the NHS, etc., to help patients and ultimately patients understand the scientific data that is presented to them.
Yeah, I'll be exploring about what we've got right and what we've got wrong in this. I'd be really interested, because I think, there's so much that I think we believe we're doing right, and so much we're probably getting wrong, and sort of having a bit of a discussion about that was what I was quite interested in. And Melisa, what did you think?
I think my personal perspective is a little bit different because I lived in a different country, and I trained myself as microbiology in different country, and I used to work as well in public health sector, and it's completely different to how we handle here everything. So obviously my personal perspective, it will be the obvious one, that we have so much to do in terms of, at least in my country, Central America, we have so much to do in terms of method standardizations, AMR surveillance, I don't know, data management and all of that kind of thing. So it's very basic for us, but for us, it's just a big step that we have to just overcome. So I'm quite interested in all of this at the moment.
And I was really interested in your perspective as well around having to interact with the healthcare system in a different language.
Yes, it is. But I mean, I've been living here for a long time now. But in terms of handling antimicrobial resistance, I still have in my head imprinted what I learned from over there and how we used to handle everything and the issues that we used to have in terms of like even to lack of reagents, the miscommunication between medical team and the microbiologist team, the lack of trust in results, the use of private sectors, self-medication of the patients, because some of them, they couldn't afford to go to the doctor or pay for a clinic. So for us, it's easy to just go to the pharmacy and say, give me some amoxicillin and tetracycline, treat a common cold. And my mom does that. She's still doing that. And I can see how in here we have so much done in many ways, but we still have quite a lot far away in Latin American countries or low-income countries to tackle that kind of, to get into the same level.
I'm waiting on the next operation now, which, if everything goes to plan, will happen fairly soon. Straightforward operation as it goes. I'm going to have plastic tubes put into my leg to act as veins. The scarring will cover my leg, growing to knee, but that can't be helped. As for now, the femoral vein is tied off. Not tied as in a knot, no. Clamped with... I mean, I want the operation over so I can get back to normal. Whatever that is now. But the doctors want to be sure that I'm not using during this period. Fair play, I get it, of course I do. But I've been with heroin since I was 17, right? And it's up here. And I know where to go and get it, whatever the situation is. I'm not injected, no, I'm booting it, smoking it. But it can't be in my system, because the doctors won't operate. Simple as. I know how to get it out of my system quicker. I'm devious. But it's a cat and mouse game. A vicious circle, if you will. I mean, I want to use because I'm bored or whatever the trigger, yeah? And I can't go out and sell. Not like I used to. The crutches. Not that many people about, yeah? Selling the issue is important to me. A focus. I'm representing the company. It's a job, basically. In a way, I'm representing the homeless.
For example, in the context of Colin, despite needing medical attention, he's eager to go back to what may constitute as his normal life on the streets in order to sustain himself, which is his addiction in this case. And so it would be futile to try and convince him that his hardship is secondary to the global health goal of tackling AMR. And even if he was concerned about the dangers of his drug addiction, such as the possible treatment failure in infection recovery, he'll likely be treated with antibiotics at point of care and also probably prescribed to take additional ones at home. And he may still be likely not to follow the given course, as his understanding of antibiotics and AMR may be somewhat limited, causing him to take antibiotics in very irrational manner.
And I wonder whether, as well as developing the academic theories, we need to be engaging with charities that are in that sector who are actually providing things like one-stop shops. For the charity that I am involved with, moved their premises so that they could provide multiple different cares for their clients, so things like hairdressing, GP access, pharmacy services, computers, all that kind of thing, because quite often people will come into a place and they won't necessarily go on to see the agencies that they need to separately. So perhaps we need to be doing something like bringing their AMR education to them as part of those services, in those kind of central places that they access regularly for food and for clothing and washing and things like that. I guess maybe we need to be talking to people who are in that situation a lot more about how they can, how we can help them to get the right treatment.
So my thoughts are, and I've been told off, so I'm just going to share this telling off that I once had, is that people who are maybe homeless are not hard to reach. We think they're hard to reach, but they don't think they're hard to reach. And the language that we're using is not really helping them to reach it. Francis, you stated you knew where they were. You drive past them every day. So I think there's something around, by virtue of discourse, we're making them hard to reach by calling that group hard to reach. And it's just a group with different behaviours, isn't it? And different ways of living to the way that we live and work. And in terms of treatment and support and understanding medication, if we're looking at drug users, I think actually they have a very good understanding of drugs. They have a very good understanding of, certain how to acquire the drugs that they want to feed their addiction, and also how the system can support their addiction in that space, and the consequences of, taking too much of the drug or mixing it with certain drugs. There's an inherent knowledge often with a drug user around the drugs that they're using and the acquisition and use. So I think exploring that space with people with that lived experience would be the most valuable way to understand how to work in that AMR space, to take ownership. And just sort of incidentally, in my own personal life, spent some time with communities that are living in homeless shelters and in spaces like that. Generally a really good understanding of some of the things. The behaviours maybe don't show that. There's some really good understanding around the planet, the way we look at sustainability. A lot of people have made decisions around not living in a certain way because of their concerns around the way science is used, drugs are used, or our carbon footprint.
So true though, because it's right. Like people know about AMR being out there, but then it's not until you have an in-depth conversation. Even like my friends, like when we talk about the job as a microbiologist, and they're like, "Oh, you do this. Oh, you look at this. Oh," and actually, they don't realise the whole complete patient pathway of everything that goes towards that. Everyone that's involved, from the clinician to the laboratory, the pharmacist, and actually seeing everything. And I think sometimes when we're engaging or publicising that information regarding like AMR, it's kind of, we try and hit the key points that, there are resistant bugs out there. Oh my gosh, it's an issue. But then how far does that message travel across? I think people are aware, but then I guess there are still behaviours where people maybe, taking, and, they don't realise what needs to be done in order to try and make those improvements. But I think it's when you do have those in-depth personal conversations, you really then, I think, have that impact. Because, if you talk to someone who kind of has that knowledge, you can really get them to see what we do. I mean, from like a laboratory perspective, so we work quite hard to try and do rapid identification so that we get an identification of bacteria quite quickly, and that changes what treatment a patient is put on. And so when people realise that, they're like, oh, and we want to change the treatment so that the patient's on the right antibiotic at the right time. So a lot goes into that. And
if you had a take-home message for the people out there in regards to AMR and reaching these hard-to-reach groups, what would it be?
Probably let's talk. Let's talk, let's listen.
Probably something very similar to Jane. I think I liked what Jane just said. Don't think they're hard to reach. That's the problem. I think we're putting false barriers in the space. I think it's up to us to understand and we can only understand by co-producing and engaging. That's what I think. Yeah. But not just for AMR, I think of that for everything, really.
Well, I think the same. I think it's that, and I think it's breaking barriers as well. Like we said, there is this kind of a stereotype to, oh, this person's homeless. You're assuming all these things, but actually, do you know about them? So I think it's breaking barriers, getting rid of that unconscious bias as well, like in your head that, you know, you make that assumption that actually, oh, this is a homeless person. This is, you know, why, yeah.
I tell her it's two emotions. In the morning, I'm so fired up about the science that I often put my clothes on inside out. But at night, when I'm leaving the hospital and I go past all the patients in the wards and, you know, who for different reasons don't get to go home, and I tell my grandma that my job makes me both humble and proud in equal parts. In the morning, the science fires me up, and at night, you think about the patients that you're leaving and it reminds you we're all human. None of us immune. It's not routine what we do. We're not machines.
Paul? Is that you? Kitty? If you can hear me, it's not what you think. It's not the samples. It's everywhere. The infection is in our building, our communications, the ventilation system in the lab. If there's positive pressure after the power outage, it's pumping out airborne bacteria, airborne virus, not just the measles, our Cat2s, 3s, fully drug-resistant TB. You have to get out now!
Hi everyone, I'm Lena Sirik. I'm an associate professor in environmental engineering at University College London. I'm an environmental microbiologist and I'm really interested in, I guess, finding out where microbes live in the areas where we live, you know, in our homes, in our schools, in our offices, in our hospitals, and trying to figure out why they're there and how we can maybe address the balance between the good ones and the bad ones.
Hello everyone, my name is Saskia Marland. I'm a theatre maker and a director and a facilitator who also works a lot with young people. So as a theatre maker deviser, I have a theatre company called Urban Foxes Collective. We make work that is quite experimental, comedic, absurd, very much grappling with big questions, a lot of themes that often we feel like terrorize us or, you know, stick in our head and we can't stop talking about. But we like to deal with them in a kind of more comedic, absurd way as a way into big, difficult themes. I also work as a theatre director as well. Working with young people in lots of different contexts.
Hello everyone, my name is Monica Gravagno and I'm the theatre maker, a deviser and also a storyteller. I run a physical theatre company here based in London called Faccio Cose, and the work we do is really about telling stories of invisibility. So as theatre makers, we really work on finding out what is invisible we can't see, and we really work on understanding how to tell these stories of things that perhaps as Saskia said, might terrify us as microorganisms because we can't really see them and we don't know what they do.
interacting a lot with green spaces or with pets, have more, well, better developed immune systems and fewer allergies than those that have, you know, whose parents have been spraying Dettol everywhere. So that, you know, that's a sort of nice positive message to put out there, that actually interaction with microbes is a good thing. And in fact, you know, the way that we're born means that we encounter our mother's microbes immediately, and they colonize our own bodies and actually help us digest the milk that we are fed in those initial months and stuff as well.
I will say, yeah, definitely, because we were doing some tests as well for our next project to understand which kind of audience we would more likely engage with, and also why, no? Maybe because, for example, engaging with our young audiences because they don't know, and there is a need for them to know more about microbiology, or maybe engaging more with adult people just because they can make more choices in the way we shape our planet and climate change and so on. And I think what I found out is that definitely there is a young audience which is much, much more interested as well in, I would say, in multidisciplinary approaches, no? So, for example, approaching science, but not just from a health perspective or medical perspective, but maybe more from a theater perspective or creative perspective. And they're much more interested in knowing about what's going on around us in the world in ways that are much more playful as well, engaging, and definitely multidisciplinary.
However, I think we're definitely moving in the right direction, and now, you know, we have new researchers, you know, finishing their PhDs who actually aren't just within one discipline, but are across a number of disciplines, and they won't know what it's like to be stuck in one discipline and have problems understanding somebody else in another discipline.
Yeah, like different teaching techniques. I think that's so interesting as well. Like, I just think the play is such a wonderful thing, and I totally understand what you're saying about the, oh God, she's going to make me dance as a microbe. How does a microbe dance? I was like, I love that.
I'll try a few things later and let you know.
Yeah, and I think there we go, mate.
This is my house. Me and my husband bought it 8 years ago. I haven't lived here for nearly 7 months. I lived here. An A&E visit that turned into a 6-week hospital stay. Turned into a 6-month hospital stay. I call my husband. Hey, it's me. Yeah, I'm just back at the house because I just... No, everything's fine. She's okay. He thinks something's happened to her. Every unscheduled phone call from me plunges him into panic. And I can sense the fear in his voice. Just thought I'd come back and get some fresh clothes and pick up Fredbear, because she's been going on about Fredbear all week, and I just thought I'd just come back and get it. So. Well, no, she had a 2-hour session booked in with a play therapist, so I just thought, well, she's not on her own, is she? She's been in there for like over 7 months. She sees her every week. She knows who she is. But I'm scared too. I'm hurt.
Hello everybody, I'm Professor Mark Fielder. I'm a microbiologist who works in the area of One Health and especially in relation to antimicrobial resistance. So what I'm interested in is how antibiotic resistance impacts on other people, how it impacts on other animals, and how it impacts on our lives. And that's really critical, I think. When we think about antibiotic resistance, most of the time we think about an organism that we can't treat. But on the other end of that, there is a patient. Whether that patient's got 4 legs or 2 legs, that patient is at the mercy of the organism that we either can't treat or have difficulty treating. And I think one thing, if we think about the video that we've seen recently, the me and her video, that really emphasizes the discordancy that antimicrobial resistance can cause when somebody's in hospital on a long-term basis and they have issues which mean the family is split up, which means that they are potentially facing a really uncertain future, and all the problems and concomitant issues that come together that make a nasty situation medically become a socially difficult situation. And I think that video brought out a number of different aspects, including the relationship between the mother and the father, the relationship between the child and the parents, the difficulties with the parents and the child being split up, the nervousness, the panic, the uncertainty, and also, interestingly and importantly, the role of animals in the whole dynamic of what was going on, because there was a clear message there about the family pet.
That video really brought home sort of the human cost that we don't always tend to see, especially when we're researching AMR. So I'm a bit similar to what you do, Mark, in terms of I'm interested in antimicrobial resistance from a One Health point of view. I look more at the animal end, and then that interface with people, whether it's through contact with animals or through food or through the environment. So a lot of the time we're a bit more removed from the issue.
Yeah.
And you kind of forget that human cost is sort of invisible a lot of the time, AMR.
Like when you talk about farm animals, obviously when one of the big resistant issues that we're really interested in is like pan resistance, which means we can't treat patients at all for things like Klebsiella. And we've had some of that come about. But when you look at tracking where that happened, it happened because of the fact that we had humans and animals living in close proximity. And then we felt like we might have had spread through birds. And we talk about this as if it's a new thing, whereas obviously, you know, the 1918 flu pandemic happened because of the fact that we had humans and different types of animals living in really close proximity to each other. So this isn't a new thing. This goes back centuries, and it's so complicated. And I think that the video by Becky did a great job of showing that human impact. And it's even harder because I work in paediatrics. So I work at Great Ormond Street in infection control. If I have to stick a child who's learning to walk, who's learning to talk into isolation for, you know, sometimes we have patients that will stay for 12 months, they'll stay for longer because they have complicated conditions. That's a long time to lose out on that developmental part of your progress. You know, you may not catch up from that in the same way. And I have a lot of conversations with families about the fact that they bear the burden of this cost in order to protect others. And I suppose that's kind of societally what we're trying to do at the moment. And it's not always an easy thing to ask of people in order to, you know, people want to put their child first.
I mean, there's no doubt that we share, as you know, a lot of bacteria between us and pets. There's been quite a few studies that show things like E. coli, which are commonly found in the gut of many different types of animals and people. You know, you can see the same types of E. coli in the dog that lives in a household and the family. And, you know, we definitely know transmission goes both ways. There's quite a few studies. I guess it's hard, like what Elaine's already said, that self about that quantification of what the role is in terms of transmission. I mean, we know from the work we've done, you know, standard dogs, if they're not on antibiotic treatment, you know, the prevalence of important resistance mechanisms that may cause issues in a patient in a clinic are not very common. However, we know that certain activities, you know, if dogs are on antibiotics, if dogs are exposed to farm animals, we know our dogs have disgusting habits of eating the feces of other animals. I know my dogs do.
And the fact that science can react. Science does react. Look at the last 18 months. You know, we've gone from, wow, what is this thing? Where's it come from? To here's a vaccine. and we've got a nice, safe, efficacious vaccine from various different sources that is working really well, and it's helping us get through the pandemic, along with all the infection control, along with all the changes in our behaviours. But it's positive, and we can do something very similar with antibiotic resistance. So let's see if we can now think about, can we possibly perhaps utilise something like vaccine technology in certain bacterial diseases. It's done in the animal industry quite a lot. Why can't we translate that over into humans and see if we can protect ourselves from getting infected, as opposed to dealing with the infection once we've got it?
And also that behaviour piece, I think we have seen how important behaviour is. And from my personal point of view, it's actually been fairly easy for people to step back for the last kind of 10 years, 15 years to go. Science will solve this. So science can solve a lot of things, but actually our behaviour isn't completely separate to science. Those two things overlap, and we have to think about how we do that education piece, how we all act as individuals, and what our behaviour is like across those boundaries in order to really impact this. You know, how do we deal with outbreaks in other countries? How do we deal with migrant health? How do we support that global infection picture in order to make sure that we're doing all the right things? Because it's no point in us kind of going, oh great, in healthcare I have wonderful antibiotics in this country, and completely forgetting that there's large parts of the world that don't have great access to antibiotics, and therefore may be forced to use them inappropriately because it's all they've got. We have to stop seeing this as them and us and start seeing us all working together on this one.